Okay, assalamu alaikum. Good morning, everyone. It's a great pleasure to be at the conference that we all cherish and love to be here in Cairo on an annual basis for the ASD. I'm delighted to really be with this elegant co-faculty, my very good friend, Dr. Tatiana Mirankovic from North Macedonia, and Professor Hazim Ashmawi from Cairo. And we have now a very important session on therapeutic patient education. We very frequently talk about management, about the latest drug, about the latest technology, and we forget the basics of diabetes, which is therapeutic patient education. And perhaps you can introduce the first speaker. You know him very well.
Actually, I have a pleasure to know him very well. It is Professor Joao Raposo from Portugal, Spain. He's, sorry, from Portugal, Lisbon. It is a big mistake, I'm sorry. And he is a president of IPDP. It is the oldest, how can I say, the Faculty for Treatment and Education for patients with diabetes. So he works as well with WHO in the problem of diabetes and non-communicable diseases. So today he will speak about therapeutic patient education.
So good morning. Thank you for the nice introduction. And I must say that it's a pleasure, real pleasure for me to be here. So all my life I was dreaming to come to Egypt. It just happened that in the same year, this is the second time, I had the pleasure to be here in April this year in a very short meeting on therapeutic patient education and support that the World Health Organization, the EMRO, is trying to implement here in the area. And so it makes all sense to speak about therapeutic patient education, and I hope the same will happen after this communication. So, and thank you. I have really not to forget to thank the warm welcome, all the organizational effort. I really felt pampered in those days here, and I really have to return just to spend more time here, and it's a great, fantastic country. And so what I propose to do in the next 19 minutes, thank you for that, it's to speak about therapeutic patient education. I put this title, Lessons from the Past to Build a Better Future. And you've heard all the places where I work, there are quite a lot. And just start with an exercise, and this is a real exercise that I've done it last year with a group of young adults with type 1 diabetes, and I asked them to think on one word that you link to diabetes. So just in your mind, can you imagine what kind of words would people living with diabetes would say? Just think, but I'll have some of the answers here. So words associated to diabetes would be sugar, lifestyle, empathy, boring, fight, family, needles, challenge, strength, partnership, resilience, physical exercise, life. Probably not very surprising, the words they would associate with type 1 diabetes, but even so, when you see family there, they were mentioning the difficulties in relation with the family because they have type 1 diabetes and how they feel judgmental, to be judged by the family. And so, even when we see just one word like family, we never know exactly what's behind in their thought when they speak about that. But there was a second question, and it was think on one question on diabetes that you would like to be answered. And so, again, those were people with type 1, adults living with type 1 diabetes for more than 10 years, and still the questions they had was something like that. How many types of diabetes exist nowadays? And we have just had the previous talk on LADA, and there are some more terms nowadays. Still, other questions that I would never thought on that. Is the insulin produced by pharmaceutical companies as fast-acting as the one produced by our body? Is the life expectancy of people living with diabetes different from people without diabetes? How did people manage diabetes before insulin was discovered? what is the impact of neuronutrition on people living with type 1 diabetes, how is to share a life with someone that has not diabetes, should I be worried with the number of brain cells that die during hypoglycemia. And so, just to remind us that sometimes even when we try to do our best to provide information, we still miss a lot of the important things that people would have in their mind. And just about the neuronutrition, it's the relevance of social media. At that time in social media, lay social media, there were a lot of talks about neuronutrition, and so they were very interested to know what happened with type 1 diabetes. Again, meaning that when we are addressing people's lives, sometimes we, healthcare providers, are just missing some important topics that they would forget. And so, just another short example. So, a clinical case of Susanna, 58 years, type 2 diabetes, diagnosed 5 years ago, A1C of 8.2, a BMI 29, dyslipidemia. And for us, healthcare professionals, it would be very easy to go immediately trying to provide counseling based on that. And so, what we have here, we keep always judging. So sometimes we just started, you should be more careful with what you eat and cut on fats, because we've just seen dyslipidemia and high BMI. But she would say, I'm careful and don't eat almost no fat. So we didn't ask that. And we would keep, and you should do more exercise. And she would say, I'm doing exercise 3 times a week, I'm losing weight, quite happy with it. But she was worried with nocturnal hypos. They've become quite frequent last month. And so sometimes, with the question of time, and we are always complaining that we don't have time for consultations and to speak with people, but with that, we immediately go to judging and providing counseling, information, and we miss most of the important things that people that really have to take decisions on themselves, we are missing their needs. So on therapeutic patient education, was there a past on this? What's the present situation? Can we foresee what will happen as therapeutic patient education for the future? And just to tell you that in the past, and so this was written by Bunting, as you can see in a talk in 1924, so shortly after the introduction of insulin. And what it says there is no disease which requires such an intimate cooperation between the physician and patient as diabetes mellitus. Patients should be thoroughly instructed in the cause, course, and complications of their disease, and should be taught on different things. So, from the start, and so that's why I wrote that think on the past, insulin discovery on type 1 diabetes at the beginning, and now with type 2 diabetes, it was evident from the start that the involvement of people living with the condition was an absolute condition to have success as therapy. So as Professor Mohammed was just saying, we could have the latest drugs, we can have the latest technology. If we don't have the involvement of people that have to live with the disease every day and have to take decisions every day with that, if we don't do a complete work on education, we will always be surprised because we don't achieve the aim success. And so it's something that we really have to introduce in our consultations, in our centers, and find a way to do it. Otherwise, we are just forgetting the most important thing on the process. And so, and Professor Tatiana was mentioning APDP, and at APDP, the place where I work, that's the oldest diabetes association. And it's what's written there, again, kind of yellow, old paper, but translation is here. In diabetes, the doctor must be a teacher more than in any other illness. His job is not so much to treat the patient, but to teach him how to treat himself. Yes, they explain the basic ideas about the physiology of the illness so that the patient can understand the therapy, and that traditional relation between doctors and patient has to undergo changes. And that's something that also we don't have such thing train ourselves, because we are used to say to the patients what they need, what they should do, but actually they'll do a completely different set of things if we don't involve them in the process of the decision. And so the success, and again, just to tell you that this was written in 1925, education is something that's paramount in this process. and some old images of the APDP, the association. So again, remember, this was an association created for poor people living with diabetes, so they couldn't afford the price of insulin, and we were just providing insulin for free. But education, as you can see in the images there, it was something that was done in a group education, individual face-to-face consultation. There was a kind of a kitchen to tell people and to teach them how to cook, choose wisely the kind of food. And so it's possible, even in a very low resource environment, to have success providing education. So that's another message that I would like to give you. We can make best use of our time, we can make a better use of our resources. And then when we speak about therapeutic patient education, we always come back to this paper that was published in 1972 by Leona Miller on what happened in a poor community again in Los Angeles, United States. And so what happened there is she and the team just changed the process of providing health care. And so, as you can see there with the red underline, it's a new way to obtain healthcare needs. So the focus again was on the needs of people. People would go immediately to emergency department if they had needs, and now we just provide another environment to have better results. And the better results, and this is what proved that therapeutic patient education was something very important, even, as I told you before, it was there from the beginning since the insulin use. So what you can see here in the graph is even if the population covered by this hospital doubled, now it's more 50%, from 4,000 to 6,000 people, the number of people that would recur to the emergency department was half of the number, so or almost a third. So it's the more efficient use of our resources. So again, it's possible to have better use of our resources. In 1998, the WHO working group from the European region published a book, a small booklet that's available on the internet on therapeutic patient education. On that book, it's mentioned that therapeutic patient education, TPE, are a bunch of activities essential to the management of pathological conditions managed by healthcare providers duly trained in the field of education. And I don't know your experience here in the room, if you have received a good training on the therapeutic patient education, but at least in my country, it's something that we don't have it, at least in pre-graduate courses. And the idea of therapeutic patient education, it's designed to help patients, families, to manage their treatment. It's to prevent avoidable complications while keeping or improving quality of life. And so the idea is to help patients to self-manage. Do you get it? Prevent avoidable complications. And the results nowadays, when we see the results on diabetes, they are better, but probably could be better even. And the quality of life. Do we really know what's the quality of life for each individual patient? Are we able to, do you have in your clinical records what the patient's values for their life? It's walking, it's watching TV, it's being with kids. What's the relevance for each individual patient about what they value for their life? Because even when we have the best guidelines, people strangely don't adhere to treatment. And so when we're speaking about exercise or even pills or even injections, as you can see from many published results, it's like between 10% adherence, in the best case 80%, but usually it's about 50%, 2/3 of people adhering to treatment. And the more prolonged treatment, and we are speaking about chronic conditions, less people try to adhere. And so we really have a problem on involving people to keep on their best treatment, and strangely, it's the best treatment for them. It's helped them to avoid complications. So why don't they follow those rules? What are we missing? And so, what happens when we don't have good results? We go back again to the same data, some conclusions, and this is the new book on therapeutic patient education from the World Health Organization. New design, but probably the concepts are still there. So again, structured person-centered learning process, supports individual living with chronic conditions to self-manage their own health by drawing on their own resources, supported by carers and families, carried by trained health professionals, adapt to patients and their conditions. It's a lifetime process. So it's not one-shot process. I give all the information. I teach them how to use the glucometer or how to inject insulin, and that's it. So it's something that we have to keep good register of it, and because we are going to see these patients through their life or our life, and we have to be sure that we can address all the evolving needs of patients. And again, therapeutic patient education can help to better health outcomes, improve quality of life, while making best use of healthcare services and other resources. And that's quite important because when we discuss with our bosses, they are always complaining about we are wasting resources, and we have to be able to demonstrate that TPE is really helping us to have the best use of resources. Otherwise, they would be spending medication, technology, consultations, and they wouldn't achieve the success they are aiming to. But sometimes we don't have a good organization for TPE. So we always think that providing education to patients is just to give information, a leaflet, a booklet, a video mentioning an app. And actually that's not addressing patient needs. So in this new guide, the World Health Organization says, well, there are at least two components. Sometimes they are quite mixed, but at least in our minds, we should have a good structure to provide therapeutic patient education. First component, it's about goal setting, action planning, and shared decision making. So how can we, with the patient, share an acceptable plan for the future steps of therapy? And then, after achieving that plan, we have to think on how to deliver education. So just think first, when seeing a patient, that we left what are their needs, what is at that moment, what does he accept to do, and then think how can we do that. Sometimes it's really just to talk, sometimes it's to talk and provide a leaflet, sometimes it's just to advise him to go to a group education, to a community resource, but it's a structured process designed to help patients to achieve competencies that are needed for him or her to better self-manage their condition. And at least in my country, the best place to provide education is on the normal consultation. And so we try to integrate all the steps on education in a normal consultation, in a 15-minute consultation, sometimes a little bit more, sometimes a little bit less. But we just try to train our healthcare providers to avoid saying everything in one consultation. And you know that's quite tempting for us to speak about all diet, physical activity, medications, control, and every aspect in one consultation. And actually we are dealing with diabetes. We have time, and we have to be sure that we have time. And if we try to address everything in one consultation, people are not listening, we are repeating ourselves. It's boring for us, it's boring for patients. So again, therapeutic patient education probably is the best way to use our time to be innovative in each consultation with our patients. And it's good for them also to think that we are providing new information, new ways of saying some of the concepts that are really needed for them. Just to show an example about the stage of disease acceptance. You know, well, there are several classifications on diseases. When you get a very heavy diagnosis, like diabetes, first one is usually starts with shock, then denial, and you move on with all the other ones. And I just show 2 examples that we use as training.
Disseram que eu tenho diabetes
We don't have the sound here,
e que é para toda a vida.
but
Disseram muita coisa,
just
a alimentação, exercício físico, a medicação, deram muita
Just-
informação, mas eu nem sequer estava a ouvir. Nem sequer consegui perceber quase nada do que me disseram. Disseram que é para toda a vida.
Portuguese.
Bem, finalmente convenci-me que tenho diabetes e que as coisas podem correr bem. Tenho mesmo é que aprender a controlar tudo e conto com a equipa de saúde para me ajudar, não é? Cada vez que tenho alguma dúvida, telefono, vou ter com eles, pergunto, não deixo passar nada ao acaso e tenho que controlar as coisas todas muito bem. E pronto, e esperar adaptar isto à minha vida. Sou eu, tenho diabetes, vou tentar adaptar a diabetes à minha vida e há de correr tudo bem, com certeza.
What we try to do there with these videos is to train the doctors and nurses to how to design the intervention when patients are in different phases of this disease acceptance process. Because we usually don't have the time and the capacity to recognize. The videos are quite easy to use because they are extreme cases of being in shock or being in the negotiation process. Sometimes patients are in between phases, but we have to be able to recognize those phases and be sure about strategies to be used. And so in that stage of shock, people don't hear most of the information. And again, it's when they get the diagnosis, and we try to provide all the information about what is diabetes, what is hyperglycemia, hypoglycemia, diet, everything in one consultation. And so we tend to give too much information. And the idea at that moment is just to provide some support to adapt this minimum information that people really need at that stage, to be objective and be sure that people don't get lost in the process. For the second stage there, it's when the people are already aware of the disease. And so it's something that when we start to speak about that, healthcare providers would say, well, really, we don't want to negotiate with patients. So 10 years ago, doctors wouldn't allow to be negotiators. Now I think we all agree that we are good negotiators and we have to do that. And I know that's the time that ended, but just to, so I gave you the example of different disease acceptance models, and then it's the language again, the kind of language that you use. Just to show 2 examples in what happened in Australia between 2010 and 2014, see what happened in the newspapers there. So the word diabetic would go out. Now we have people living with diabetes, not disease, condition. And that's, I know they are just words, and we are always using words, but we all know that words are important and relevant when dealing with people. And sometimes we try to forget that. Because we don't have time, we just move on and forget it. But words are really important. And so in many countries, including mine, we have that group of language matters. And so just to remind us that language can have positive and negative effects. And so we have to try, even in language, to show more empathy and be person-centered, to be less authoritarian, disapproving or stereotyping, and be aware of the importance of health literacy and explore individuals' cultural beliefs about diabetes. And so, again, what I'm trying to show you during these 20 minutes or a little bit less now, it's that we are healthcare professionals. And this is not only about choosing the right drugs and the right technology. I think the most important part of our job is really to be with people and support people to take those decisions. It's about our relation. So it's a kind of art also. But even for art, we have to train ourselves. We have to learn. And therapeutic patient education is something that we have to learn. It's not common sense. It's not just being polite. It's the competencies needed for healthcare professionals. So discuss within your content, within your facilities, how can we, even when working alone, how can we do a better job? So, because we want people in the future living with conditions to make questions like those one there. What can I do to improve the outcomes that are most important to me? How can the health system improve my chances of achieving the outcomes I prefer? And we are not ready for that. If patients start to ask all those questions, we'd be sometimes in most difficult time saying that we don't have time to discuss this now, I don't know, ask another colleague. And this is a slide that I've discovered during COVID time, and it was published in The Lancet, and it was diabetes like COVID-19 is a wicked problem. And the wicked problem it's a concept from the 60s, and it was based on the realization that purely scientific solutions to societal problems are doomed to fail. And that's something that we try to do with diabetes. We try to say, it's easy to solve, you just provide the medication, sensors, whatever, and people would have their problems solved. Actually, it will never work. And so the idea there, it was to construct a digital diabetes ecosystem, and it should be connect personal consumer, physiological data, behavioral data, psychological data, environmental, genetic data, understanding also the social preferences of the patients. And so if we don't have a full portrait of all those dimensions, again, we are doomed to fail because diabetes is a wicked problem. To conclude, people living with diabetes would benefit from being heard, being understood, and being involved. Are you sure that you have all those dimensions taken care when you do your consultations? And this process has to be co-managed with trained healthcare professionals that recognize and target patient needs, are scientifically robust, education is also a science, and combat our clinical inertia. Because we're just saying, and for us it's easy to say, these are bad patients, they don't listen what we say, so we don't move on therapy. If we have successful therapeutic patient education, we would have better adherence, not 100% for sure, but probably better quality of life for patients and for ourselves, and better health outcomes with earlier control, less complications, and simplified treatment. And so the challenge nowadays is to implement therapeutic patient education around the world again, and really think on how to implement therapeutic patient education. How can we have better healthcare professionals train on healthcare professionals? And that discussion starts with us. Thank you so much for your attention. I leave you with a challenge. Thank you.
Thank you very much, Joao, for the excellent overview. We have a bit of time for some discussion. So perhaps I can start with the first question. The health system in Egypt here, the vast majority of patients are treated by a doctor in his own clinic. It's not a center. It's not a large number of doctors. Certainly the support from a dietitian or a nurse educator or a pharmacist is not there. Mm-hmm. How can the individual doctor sitting in his own clinic implement the principles of therapeutic patient education? Can they do it, or do we need a dedicated education centers that we would refer to our patients?
Excellent question, as usual. And probably the solution would say both of them if possible, but what we have to say, I like to think that we have to introduce therapeutic patient education with the resources that we have at the moment and fighting for having better resources. So first point, as I try to demonstrate, even when we are working alone, even when we have just one facility and we are just doing our individual consultations, doctor, patient, it's possible to do it in a different way, with better use of our time. Because when we analyze individual consultations in many different settings around the world, we are really not so different from each other. So we keep our time, and we know that we have very limited time, and even if you are working in our individual practice, we try to make the best use of our time. And we try to say everything again in snapshot. So how have you been doing since the last time? Have you taking medication, any major health issues, and trying not to listen to the major health issues that patient would say. And then we just start. Remember, you have to give 10,000 steps, you have to eat less bread, something like that. And perhaps we'll have to increase 1 pill of this medication or 2 extra units of insulin. And that's a kind of repetitive process. And so again, we can do better in individual consultation if we have this structured way of providing consultation, spending our 10 minutes in a different way. That's possible. And that's possible now. It's possible to do it different just now. We don't need to involve anything else. Because we might not even have educational materials, leaflets to provide, but the things that patients value, it's our relation. They come to us. Here nowadays, they have information all around them. So it's not about having leaflets or something. It's something they value to be with the doctor. And so if they value that moment, we have to be really providing value for them. And that's the value of therapeutic patient education. Of course, we can do and aim for having other kind of support resources. Again, it's the leaflet, it's the educational, it's the having educators or diabetes specialized nurses. But again, if we as doctors don't provide and start the process, the patients wouldn't go to the educators. They would miss because they say, well, my doctor said to come here, but I really don't see the point because he already told me what to do. And so we have to have a strong connection with those supporting structures. Otherwise, we're just implementing things that are not going to work. Yesterday, we were discussing that even in the UK, people would miss to go to educators because they really value to be with the doctor. And so why not involving, when we are, as doctors, with the patients, trying to discuss with them why it's relevant to go to the educator and negotiate with them why it's important for them to go. And they would accept, if they would understand the value instead of just being a simple prescription, probably they would go. But we try to really not to design things based on the patient needs. We just try to follow a guideline. And it might be that in UK it says, after a diagnosis, people living with type 2 diabetes, they have to go to an educator to have a trained process. So it's just like a normal guideline. And if we fail in the guidelines for therapeutic, for any pharmacological treatment, we also fail on that. So again, education, it's what integrates the process of care. And anything, any brick that we introduce in the process has to be integrated in the process, and actually it has to start in our relation. It's all about our relation. Long answer, sorry, Mohammed.
Thank you so much for this highly elegant and comprehensive lecture. My question about the degree of acceptance and adherence to both types of advocacy messages regarding direct face-to-face from healthcare professionals or indirect messages, for example, through social meetings or social medias or something like this. And if there is any data about difference and the degree of acceptance of the patient and adherence, what message is more beneficial regarding the patients? What message do the patients accept really? Is the more direct message, face-to-face message from his health doctors, or for example, or healthcare follower, or from I can give him a message indirectly through something, meetings or so brochures or video social medias. And if there is any data about the difference of acceptance.
Yeah, thank you for the question also. And it's, again, very important, this, because in the past, when we're speaking about 1920s, 30s, 40s, people would get information mainly from the doctors, perhaps hearing something from their close neighbors, so they would know if someone in the family or neighbor would have diabetes, they would follow that. Nowadays, that's not the case. So the level, and that was the traditional relation, doctor would be here, patient would be down here, aiming to hear all the information, even the scarce information that doctors would tell them. Nowadays, we try to be more in parallel because we understand that it's a shared process. But with that, the trust in the doctor information or in the healthcare system information, providing information, is almost similar to something that you hear in social media by a famous influencer or by what they heard in the TV, because that person there spoke about diabetes and she's saying that that kind of fruit is fantastic for diabetes. And for most people, they would understand that as good as the information provided by the doctor or anything else. The idea, again, is we have to know the rules of the game. We have to know how people take decisions. If we can understand they are taking decisions based on social media, and that happens a lot in my country nowadays, at least I had to provide the space where they told me, where they can tell me they are listening to that kind of information, and they are able to discuss with me, and I have that a lot. Doctor, what do you think about that person that's on TV speaking about mangoes and diabetes? And she says that mangoes are fantastic for diabetes. And I have to start that discussion at that moment on that. So it's really to adapt, again, our capacity to the information that people already know. Because we try to think that people don't know nothing about diabetes, but they get information from all around. So start the moment with that discussion. Are they getting information from where? From a family, from the TV, from anything. And that's the starting point for our discussion on that consultation. And again, we as healthcare professionals also can provide, be more evident using social media. Why not? Why not having our presence in the social media? In the nice way, because usually you are boring doing that. And so...
This is behind my question. This is what's behind my question. To use the patient usually accustomed to...
Yeah, because we know they are going to use social media. So why not being there? Why not show your face using social media in a nice way, in short videos and providing that information? Because it's no use to say, don't go to social media, just listen to me. No, we have to be in the channels that people use. And we have to be trained on that, because most of us, again, we will do very boring things. I'm not doubting on your capacities, individual capacity, but most doctors are boring when going to use the social media. And so we have to be trained to use even those media.
Thank you.
Yeah.
As an example, one of for my colleagues, he used both in the same time. He made the videos, and these videos were played in the resting room of his clinics, and he used social media, and the patient were watching videos as social medias while they're waiting him in his clinic to get consultations. Thank you so much.
It helps a lot, yeah. we use the same with the TVs in our waiting areas too, with a lot of small videos about everything.
By his videos, he is making the videos. He is the one who is to speak.
We also,
Yes, but I think that the patient try to collect information from social media in general about diabetes, but there is a psychological connection between the patient and doctor, and this is very, very important. If the patient know a lot of information about diabetes, but he want to ask about his condition especially, and not in general, and this is very important. And now trend for what's called artificial intelligence use in. The question is the artificial intelligence or any machine learning devices can replace the psychological connection between the doctor and patient? It is very, very important. And for the process, you have to give your time to the patient. Is that time is a part of the prescription, not giving the patient order in a prescription. And if you have a limited time in your clinic, you will lose more time because this patient will come back again and again, not responsive to treatment. But if you consume more time for your patient, you will save time later. Really, it's bigger difference. Very big difference. If you give time for educate the patient, even every medication, your prescription, just a small hint. This is to improve your insulin sensitivity. This is increase your insulin secretion from pancreas. This is very important to make the patient understand what you are giving in the prescription, I think.
Yeah, completely agreeing with that. And about the artificial intelligence and the use of artificial intelligence, and is it going to replace what we do here? Again, while we are still humans, and I don't know how for how long we will keep our essential condition as humans, and as we recognize now, I think still we have to be able to show how important it is to have social relations. And social relations, it's about different social relations between our family, but also about going to other places. And that's the reason, at least, when doctors try to lose those qualities of really being with the patients, being there, listening, and providing individual counseling and people feeling that they are being heard, if we lose this, people go to other places where they are heard and where they are and where they have a good relation. And that's why there are so many now parallel health advisors, because people go there because, I've been to that person and she tells me that's all about my energy that's coming from some place and it's really provoking me. I'm much better because she understood me and now she provides individual counseling. Because what happened there, she's not having better treatment. She had time to be with someone that really heard her or him. And so artificial intelligence seems to solve that problem, but actually it's not. It's helping us to lose that quality. And strangely enough, when doctors, we complain that sometimes in consultation we have a lot of bureaucratic, we have to write different files and because of financing or reporting, all those things. And we never heard that artificial intelligence would help us to save that time. It's always about saving time for the clinical decisions and for the clinical judgment, which is strange because we really need to have more time to do what we are really best, that's to establish relation. And so I hope in the near future, artificial intelligence would help us to help people to get the right kind of information for them, because it's possible, because people would find their information on the mobile phone, and artificial intelligence would recognize their behavioral pattern, and so probably they would get more individualized counseling when searching information, and that's good. But, again, don't forget that we are really doctors or healthcare providers, and the relation is here.
Can I ask a question, perhaps I would ask both of you, yourself and Tatiana, being the president of the Diabetes Education Study Group. Classically, therapeutic patient education was focusing on glycemia and perhaps in mind the person with type 1 diabetes who has a complex condition related to glycemia. But nowadays, as the cardiometabolic theme becomes the overwhelming problem, specifically for the masses of type 2 diabetes, should the diabetes educator change role with the nutritionist? Should they combine role and the nutritionist and the dietitian become one person to provide advice on glycemic control, on the delivery on the device, and certainly on the cardiometabolic aspect, the hypertension, the lipids management, the smoking, and the lifestyle? Or should we still have a dietitian talk about diet and the diabetes nurse talking about the glycemia, the device, and the pen?
Well, I think so that the cardiometabolic diseases were following diabetes from the beginning. Now we are speaking a lot about it because diabetes affects so many people and they're dying out of cardiovascular diseases. I mean, it's since when diabetes exists, but nowadays even more because of our lifestyle, because of everything, smoking and physical inactivity. And I think so that the many centers, including mine, we don't have many nutritionists like professionals. I think so that is the problem in many parts of the world. So, and plus we do not have a real training for nutrition during our studying, at least in my country. I know that it's the case with many others. So when I started to deal with education, I realized that I don't know almost nothing about the real nutrition and real needs that people should know with diabetes. So it is that role. It must be divided. I mean, it must be for the both structures, and physicians must know a lot about nutrition to share with their patients about physical activity, and they should learn more. And that's why was Professor Joao's talk that we have to train those who should deal with education more than usual training that the doctor can get during their lifestyle, because the lifetime, because it is a bit specific things that they can teach their patients. But as he said, I think so that the real connection is when we became able to get into their shoes, or to understand what are their real needs and problems. And of course, we have to inform that what are the main complications of diabetes, that it is cardiovascular diseases, and they must be aware. Because we run, if you remember, with IDF questionnaire for patients. Do they get information from their physicians that they have at highest risk of cardiovascular disease? Well, maybe half of them even don't know that they have that risk. So that's the consultation is very important from both from us, and if there is dietitian, even better.
Yeah. Perhaps I can just add that I think we have to start thinking on competencies more than who should do it. So first thing, it's what kind of competencies are needed at that moment. And then it can be that we need more information on medication, information on lifestyle, diet, physical activity. They need more information about the use of technology. And so those are the kind of competencies that we have to think, what does this patient needs? So they need at this moment, it would be good for him to achieve 5 competencies. And then we have to think on the questions that we have been designing here. Who is able to deliver those competencies? I'm a doctor alone. Well, too bad. I'll have to do it. So, but if I'm going to do it, I have to learn how to do it. I have doctor and a nurse. How can I split those competencies between doctor and nurse? And perhaps, do I know that in social media there is some good place where I can learn about technology? So perhaps I can split these competencies between what I do, nurses, and social media. And so it really depends. Just an example. A couple of years ago, I went to Canada to see how they treat obesity. And actually, it was the dietitian there that was the patient manager. So doctors there, very limited contacts. Nurses were not doing nothing on the process, but dietitians were the key elements. I tried that in my country, and actually dietitians, they didn't have any kind of training to do that process. So they were not good at all doing that. And so, again, discuss competencies, and then according to the local reality, we have to know who is addressing or who will be able to address those needs and competencies. So it's really individualized as everything as we are saying just to this moment.
Yeah, I think this is an extremely important subject, and you've dealt with that very well. The take-home message for me is that there is a variation on the programs of therapeutic education for the patient. And we need to put that all together so people can be signposted. If you're working in such an environment, you can get, this is what it looks like. If you're working alone in a clinic, this is where you can get information. Signposting.
In different moments.
To different areas. There's such a variation even in the UK, structured education for patients. Some centers provide it, others don't. But we don't have the right information to suit different scenarios of where the clinician is working. But the other thing is, now we've brought in this cardiometabolic disease in the picture, and it's a lot of drug usage. What about pharma input into educational programs? not for them to deliver, but for
Yeah.
them to help us to construct programs for our patients.
Yeah.
So that if we get new drugs coming out, part of the requirement should be they should be providing non-promotional education for treatment of our patients. So I just wanted to
Yeah.
bring in, what do
Yeah.
you think is the input from
Yeah.
pharma?
It's an excellent point. I fully agree with that need, because I think most of the regulatory agencies and people that negotiate with the pharma companies just think on the value, and they are discussing the price of that new pill or the new technology, forgetting that even for that new pill or new technology, there are educational needs that have to be met. And that's never discussed, because they are always assuming, I think also because of our fault, because we assume that's always, we are keen to innovation. And so if something's coming new, it's a new insulin pump with a strange technology, we waste our time, our leisure time to learn more on that. No one's paying for that, so no one's taking care of that, and everyone's assuming that we have the right training for that. And I really think that if we want to take the best use of resources, if we want to take the best use of that new pill, that new medication, that new technology, or even the new concept, pharma companies should also have to pay part of that process. So the price of things, the price of innovation has to include the educational needs. It has to be part. Otherwise, we are forgetting again the most important thing. So thank you for raising that point. I really think it's a very important one.
If there is no other questions, so we can close, and thank again to Professor Raposo.
Thank you so much,
Excellent
Oliver.
lecture.
Thank you. It was a pleasure again. Thank you.